And individuals with disease persisting for longer than 5 years was associated with even higher skin shame. And I think this is really why it's so important to address how skin issues are affecting our clients and patients and consumers. So I would say that these statistics that I came across are in keeping with the vast majority of clients that I've worked with who name shame as one of the top symptoms they experience in their relationship to their skin condition. And it really it preoccupies them morning, noon, and night with their shame. And many have been in various forms of therapy for years, and they're still struggling. So they come to me wondering how they can shed it, how they can manage it. So this presentation came from that experience and what I have done to help them. And I would say that studies show that skin shame is associated with increased disease severity as well as increased disease burden. And again, as I mentioned, based on other studies as well, these conditions can have a significant impact on their personal lives and their relationships, on their career. And the thing is, shame doesn't happen in isolation. It's commonly associated with psychological symptoms, including stress, anger, depression, sadness, grief. Social isolation is a big one, low self-esteem, feeling unworthy, and a sense of helplessness and hopelessness. And all of these symptoms are similar to what we see in trauma, which isn't surprising because shame occurs as developmental trauma. And while the experience of shame in the context of skin disease often takes place well beyond our developmental stage, but we can tap into the neurobiology and neuroscience of trauma to help explain what happens to people and how to best to support clients and consumers using a trauma-informed lens. So why is shame so hard to exfoliate? And really it comes down to the fact that trauma is not the event, right? Trauma is in the nervous system. It's living through a particular adversity isn't what lets you know that it's traumatic. Your nervous system and the impact that living through that adversity has on your nervous system is what lets you know that it's traumatizing. I think Dr. Judith Herman said it really well here, but essentially, we are wired for survival, and our felt sense of safety within ourselves, in our environments, with others, is fundamental to that. So if you think about your autonomic nervous system, like your own personal surveillance system, always on the lookout for threats to that sense of safety, on the lookout for danger, shame functions as a signal of danger. And in this case, it's social or interpersonal danger that activates our autonomic nervous system arousal. So why this matters, because at this point, after all the other lectures, why this matters is because we know that there's this intimate relationship between our skin and our nervous system, both derived from the same embryologic layer of tissue. And this intricate connection creates a two-way communication highway with what we call the NICE network, right? Our nervous system, our immune system, our cutaneous and endocrine systems, as well as connections to our digestive system, all of which directly influence skin health. And here's the thing, right? We are wired to deal with stress and stressors in our lives. And while our autonomic nervous system is always on the lookout for cues of danger, that system can become overwhelmed when things happen too much, too fast, too soon, or perhaps they're happening for too long with too little support. When something is more than we can handle, we're wired to handle that, but we do so by moving into survival energy and using survival strategies like fight, flight, freeze, and fawn. So from this lens, I want you to think about shame as a survival response that is as crucial for safety as the fight, flight, or freeze response. So we might cope by becoming hypervigilant, maybe shutting down, anxiety, depression, or collapsing. The challenge is that these strategies that we engage in for survival can persist long after they've outlived their helpfulness, because our nervous system is concerned with our survival and will always err on the side of surviving over thriving, right? Its task is to keep you alive. And these survival strategies are designed to do that. But when we're stuck in these survival coping strategies, not only are treatments not as effective, our frontal lobes, our thinking brain goes offline, right? We can't think clearly. We can get caught in thought loops, which is one of the reasons that talk therapy and topicals alone aren't often enough to optimize outcomes, right? It may not be enough because not only can we think clearly, treatments aren't effective, but also because the body keeps the score. Brain scan research shows that traumatic memories that trigger shame are encoded primarily as a bodily and emotional state rather than in a narrative form. So, in other words, shame is a somatic response. Soma is the body, yeah? So, shame is a somatic response. It's experienced through the body and stored as a body memory, a feeling memory. So, in order to help individuals change their relationship with their skin shame, we have to work with the body. Because if we don't help people change their relationship to their shame by creating an environment or perhaps providing tools to create an environment where there's the time, space, and support to complete this stress response cycle and shift that experience of oneself, we can get stuck in a vicious cycle of shame and flaring of the skin condition. And then we stay stuck in this state of nervous system dysregulation, which we know has significant consequences. These are right. So the way that we can help consumers shed their shame is by helping them use the power of their minds and the wisdom of their bodies to calm their nervous system, to clear the way to clear skin. So if you think of your autonomic nervous system like a computer and shame like a bug in the operating system, the only way to get rid of the thought errors and the body memories causing the computer to get stuck or frozen in these survival strategies is to upgrade the operating system. And we can upgrade the system by leveraging consumer products or tools that can serve as a vehicle to help people and skincare professionals who may be delivering these products engage in experiential modalities that can transform trauma by tapping into three of the primordial themes that are wired into our DNA, which are slowing down, connecting, and that felt sense of safety. So the felt sense, coined by psychologist Eugene Genlin, it's not a mental experience, rather it's a physical one. It's a bodily awareness of a situation or a person or event. In other words, it's like an internal aura that encompasses everything you feel and know at any given time. And it encompasses it and it communicates it to you all at once. And it starts with attention to meaningful bodily sensation, right? By bringing attention to the body and listening for sensation or mood or a memory or associations, the felt sense of something, we increase what we call somatic awareness, that bodily awareness. And it's that awareness which helps us shift how we see, how we perceive, and experience ourselves. And it also supports the development of a supportive relationship to ourselves that is neither anxious or critical or dismissive. It actually is a way in to support healing our internal working model of self, which supports healing shame. And when we tap into our felt sense through our senses, we activate the parts of our brain involved in positive emotion, including love and compassion. And we can quiet the parts of our brain involved in sympathetic activation, including vigilance, pain, and negative self-talk. And we can do that by creating a ritual of tapping into our senses, whether that is orienting, right, to the shapes, colors, and textures, maybe of the product or of a tool that we are using to apply that product, by grounding and feeling our connection to the earth as we are beginning our process of applying our products, bringing awareness to our breath. I think our breath is one of the most underestimated tools that we have that we can bring under our conscious control to slow things down, right? To take an extra long exhale to trigger our vagus nerve, activate the parasympathetic nervous system to bring more ease and relaxation into the body. Leveraging our breath to tap into the power of smell and aromatherapy, which can act on parts of the brain to invoke positive emotion. And we've already talked about the power of touch. And I use dynamic self-touch, a different type of modality, where the end result is the same, right? We can enhance the feeling of security and it promotes self-awareness. So each one of these practices or tapping into the senses, especially stacked on one another, can create the time, and space to increase our sense of presence, increase our somatic awareness, inviting curiosity, compassion, and creates connection to self, which helps create that felt sense of safety, which we know is paramount to healing shame and transforming trauma. And this can be further supported by perhaps a skin health professional who is applying the product, right? Using their own sense of presence and their own nervous system regulation to serve as an anchor for the client for co-regulation, right? Because we can co-regulate together or we can co-dysregulate. So using the nervous system of another to help support our healing. So getting in contact with something inside ourselves by leveraging products and tools as a vehicle for making contact is like getting a bigger picture about an issue or a relationship, something in your life that is creating stress and contributing to the shame. So getting a felt sense of it allows you to move from being it to being with it without an agenda of fixing it or changing it, right? This relationship is what supports healing and allows for organic movement and shedding of that shame. So I will emphasize this over and over again, but I truly believe that skincare needs to be both a somatic and experiential practice to shed the shame of skin conditions. And it starts with that somatic awareness. The felt sense increases our capacity to tolerate stressors, tapping into our senses, right? Sight, sound, smell, touch, all of them, and especially sequentially and stacked together. It activates our rest and relaxation response, right? We do that through our breath, through the practice of dynamic self-touch, smell, sound, and sight. And it brings a relational component of supporting connection of sense. Together, they can foster that felt sense of safeness required to turn the alarm bells off on our autonomic nervous system and create the time, space, and support to complete the stress response cycle and clear the way to clearer skin. So I'll name that this approach can be used on an individual basis. It can be supported by a skin health professional. And in these two ways of delivering the products or the tools or using these approaches can be incredibly potent. But I will name that one of the most powerful ways that we can experience this approach is by creating a community who are struggling with similar challenges. I run group programs, and I recently had the honor of working with a particular skin condition, hidradenitis suppurativa, which shame is at the top of the list for these individuals. And the focus of the program is really teaching some psychoeducation, but a lot of different techniques and practices where increasing somatic awareness through these practices is the focus and premise for healing. And I'll name that 100% of the participants reported a decrease in their skin shame, their anxiety, and experienced an overall improvement in their mental and emotional well-being, even when their skin might have been flaring, right? The biggest takeaway was how safe, how seen and held they felt having a shared experience, to explore, to learn new ways of managing their skin challenges with people who really got them. And I do think with how things are shifting with social media, we can create communities. We can, it's already being done in some ways of leveraging tools or how to use different products to create a felt sense of belonging, because shame really leads to a lot of feeling lonely and isolated. And we have an opportunity that we can shift that. So I'll end by saying that shame is a stress response and a survival coping strategy. right? It isn't a problem to be fixed. Shedding shame requires time, space, and support to be able to complete that stress response cycle. And we can leverage products and tools as a vehicle to tap into the felt sense and help increase that somatic awareness and create a feeling of security and safety, which is paramount to healing trauma and shame. So, skincare needs to be both a somatic and experiential method because trauma is stored in the body, which means we can leverage the neurobiology of trauma to innovate the kinds of products we create and how we apply them to help people not only find greater calm and comfort and confidence in their skin, but help them build resilience of their skin barrier integrity, both inside and out. So, with that, I will end. And thank you.
It's a great presentation, and I believe you are ahead of the time with your practice, and also perhaps the US market allows for that. Really great, thank you. Dr. Claudia, you are next. If you can stop sharing here, please. Claudia?
Just a second, we're 5 minutes early, so let me
start. Okay, so sorry, yes.
Yeah, and also, unfortunately, I can't guarantee no child noise because he's not in school yet. He is on his way out. So let me...
Is Alison Layton with us? Let me see. Jill.
Okay, let me see if I can share my screen now.
I haven't seen Alison join yet.
He stopped streaming, so that's good. Share screen. Okay, so I think you can see. Can you guys see my screen?
We cannot see you, and we cannot see your screen just yet.
Oh.
Yeah, the screen is coming up, so that's okay.
And then I should be here.
So perhaps just a sentence about you, if I may. I felt you had fabulous TED Talk to start with. That's how I found you originally. And again, the skin and brain connection and the translation of it into neurocosmetics, spa trends. And also your recent papers, the 2 recent papers on multisensory and science behind it. If you can mention them, please. Thank you.
Yes, of course. Okay, so I do have a little bit about myself here. I will present, and just please let me know if you can see this, because I can no longer see you guys. Can you see my?
Yes, you can see that. Thank you.
Okay, great. Okay, so a little about me and a little brief timeline. So talking about this topic, I guess I've been doing it for over 15 years, which is a little crazy to think about. And I know that this field is much older than that, but I just want to give you a little timeline of my personal career. So back in 2009, I guess you could say that I was already formulating with neuropeptides. And at that time, it was such a novel concept that we did not call it that. I was working on formulating a line for neurogenic inflammation. So that was novel enough at the time. We were dealing with skin sensitivity everywhere, and so the concept of stress causing the sensitivity rather than external forces was coming to light. And so some of the ingredients back then allowed us to tap into the skin's peripheral nervous system, without really getting too much into the nitty-gritty of it. But I did start my lectures called The Brain Skin Connection way back then. In 2012, I started working with TED Education, and this was TED Ed, and I created one of their first lessons ever, and it was on the connection between stress and skin. So it was called Can Stress Lead to a Pimple? And it was an animated sort of video aimed towards kids. And in 2015, as you can see, I gave my TEDx talk on the brain-skin connection. It was the hidden brain in the skin. So I sort of moved the scope outside into more of the realm of like synesthesia and what can we see, what can we learn about the brain from the skin, which is really where I guess my passion lies, is understanding neuroscience from the peripheral nervous system, from the enteric nervous system, and things like that. And in 2024, as we are here, we are now talking about neurocosmetics. And this has really emerged as a huge category in skincare as I've seen it. I've been, interviewed by the different media about this because of this work, because in a way we've just changed the marketing terms from sensitivity and brain skin, and now it's all like neurocosmetics. So I'll talk a little bit about that, but I want to focus on the actual neuroscience and what we know, and also what we hopefully will understand. And that will be for 2025 on. So when Katerina approached me and we were talking about this lecture, for me, my out of the box thinking is, can we solve mental health through the skin? I mean, I think we can, and this is a big question, but before we get into how can we possibly do that, I'll have to give you a little bit more background on the mechanisms in brain and skin, and I know that we've spent quite some time on psychodermatology, and I know you guys understand very well how a lot of this works. So I'm just going to touch on ectoderm, let's just say ectoderm, psychodermatology, a little bit of effective touch, and then what are these future applications? Finding new targets in the skin for a variety of things, and also can we, and this is the ultimate question for me as a neuroscientist, can we find biomarkers of neuropathology and treat them through the skin so that you're really treating the mind in the most non-invasive way? So as you all know, ectoderm, right? We have two words here, ecto for brain and nervous tissue, derm is skin, and this is because the ectoderm gives rise to the skin cells of the epidermis, neurons, and also melanocytes, pigment cells. So this is how everything is interlinked and interconnected, because at one point, the brain and skin were one and the same embryonic tissue. And I know I just heard it in a couple lectures ago, the nice, the neuroimmunocutaneous endocrine system. Everything is connected, and this is just a more recent slide on how that kind of works within the peripheral skin axis. So given that we have these established systems in the skin, I think this is how we will be able to really target inflammatory skin conditions, so more from like the outside in, and mental health, neurological conditions from the inside out, tapping into this very specific integrated system where if you have inflammatory skin conditions, then the immune system plays a huge role in this, and also the causal links between all of this we will uncover, I think, specifically within this neuroimmune system. And within the endocrine system, changes, especially when it comes to aging, and obviously female health, that's where a lot of the changes occur. And we might be able to tap into, the skin for issues of the brain and body. This is just off the top of my head as we have a couple minutes extra. Menopause, when a woman goes through menopause, her ovaries stop producing estrogens and progesterone, but her skin doesn't. So there is a readily available pool of hormones to tap into that are your own without synthetic hormone replacement within your own body. So I think in the future we will look at the skin much differently, and that's what I'm really excited about. And finally, we talk a lot about stress, and within psychodermatology, I think it's the biggest concept. And as you well know, we're talking about the response that our brain has to stress, which is with this central HPA axis. I won't get into all the details, but you know what it is. It is the hypothalamic pituitary adrenal axis, releasing these neurohormones, cortisol, et cetera, to help us go into this fight or flight. But the theory, and I think I find this very fascinating as a theory, is that the brain borrowed this mechanism from the skin. Now, if you think about us in terms of evolution and how we were just blobs on this planet a very long time ago, we were not worried about our, some psychological stress factor, but we were worried about excessive wind, heat, UV, maybe some cosmological changes happening. So, in early days, our skin was our primary defense against everything there was. And perhaps the HPA axis evolved in the skin first. As we evolved as humans into social species, our social brain grew. That's when our brain said, that is such a fantastic mechanism that we might borrow that and use that for psychological stressors. So obviously, feelings of you need to run away from danger. And now in 2024, and recently, obviously, you have an argument with a loved one, you have economic issues, war, all the trauma, even the trauma that lives on through the generations, like all of this changes our brain and body. And I just want to point how, let's get back into the peripheral HPA axis and see how that can potentially go from bottom-up processing and maybe change some of the ways that we target mental health in particular. So these are just some of these are a lot of the conditions treated within psychodermatology. It's been, maybe 30 years now that this subspecialty has really grown, and even more, maybe 40 years, where people are actually treating the body from a very holistic point of view, with different kinds of professionals involved. And even there was a paper in the 1920s about the gut-skin axis. I believe it was Pillsbury, that name sticks out, Pillsbury, that published this early in the 20th century about how can you affect something like acne through the diet. So there's a lot here. We obviously know that the mental condition affects our body, and thus all of these conditions. So I'm not going to get into too much of those details, but I want to talk about a few different ones just to, again, illustrate the axis and the connections between brain, skin, and gut, in particular with these inflammatory skin conditions. So, for example, with psoriasis, we have the peripheral axis is activated by internal and external stressors, and you can see it forms a loop where psychological stress exacerbates psoriasis and vice versa. This being such a highly inflammatory condition, it's not just living in the skin, it is a metabolic disorder, if you want to think of it that way. So it affects inflammation, it leads potentially to arthritis and things like that. And of course, it could potentially lead to inflammation in the brain as well, as we are learning more and more about the permeable membranes that we have. So we have semi-permeable membranes rather than these rigid walls. Our gut is one of these. It can become leaky, and same thing with the blood-brain barrier. Not really a wall barrier, but it is a semi-permeable membrane that also allows some leakiness to occur, and some bodily substances to go up into the brain and cause some brain inflammation. Now, we don't have a lymphatic system in the brain, but we do have a glymphatic system. So that is one way in which the brain can protect itself. But a lot of this, especially these sort of complex inflammatory disorders, are linked to mental health conditions, not just in that they are highly visible and they cause distress, but there is a genetic link with, things like depression, and how having actual psoriasis can cause potential depression. And it might not just be, due to the distress that, oh, this is really bothering me. That's a big factor. But actually, genetically, it could also lead to disturbances in the inflammatory, milieu of the body, and that can cause inflammation in the brain, which down the line can cause, different kinds of disorders. So this is a very complicated system, but it is important to understand, because I think if we're going to prevent mental illness, mental health issues as a result of skin conditions, then we have to think about it in that big picture and target specific things that might be going on within the specific dermatological conditions. So in terms of psoriasis, there was also a newer study about Mendelian randomization studies. So they looked at how there was a causal link between psoriasis and major depression, and also with bipolar disorder. And they looked at the specific subtypes of psoriasis and the genetics with that. So how that works, that's something that we're still in science figuring it out. But that happens, I think it's very important to know that something like psoriasis can cause depression on its own because of the biochemical issues. That is very important to know so that we can prevent these neurodegenerative diseases that are increasing within all of the world as we age. Another example of this is rosacea, and I'm not going to get into the details of all of that, but again, this is just another example of how rosacea is again linked to brain, skin, gut, and that people with predisposition to rosacea also might have changes in the brain, and in particular that might be due to the actual inflammatory cascades that are happening, and not just, oh, I feel very stressed, and so that stress feeds into my stress response. That is one aspect, but what I want to focus on here is the inflammatory molecules that happen, that course through the body due to an inflammatory skin condition can potentially affect the brain's inflammation, and that can then lead to different things. There is a link, I want to see if I have it here, maybe not yet. There is a link also to rosacea to migraine headaches, seeing how they both share some of these, I'll go back to the slide, how they share some of these inflammatory, vasodilation, for example, right? So you were talking about CGRP, you're talking about neuropeptides, NPY, substance P. So pain, inflammation, trigeminal nerves, so very specific nerves that can feed towards inflammation in the skin, and you get rosacea or inflammation in the brain, and you have a migraine headache. So again, in order to treat either of these, I think it's important to connect them first and see what are they sharing. Can we actually potentially treat a migraine headache through the skin, specifically when you apply it like near the trigeminal nerve? I don't know, but it's not outside of the realm of possibility, I think. And with acne, same thing. We all know that inflammatory acne is linked to our gut health. It's linked to our mental health. But more specifically, how does that work? Is acne, this is a chicken and egg problem sometimes. Does the psychological stress trigger the breakout, and or is it the acne itself? And I do think that it's both, right? You can have a pimple from stress, but you can have full-blown acne in your teenage, adolescent years because of all of the different factors that affect the pathophysiology of acne. And that, again, that inflammation on the skin being the largest organ, the most innervated organ in our whole body. Imagine all of the inflammation. When you're near the head, you're in the head at this point, all of these skin conditions, right? So to cross the blood-brain barrier, causing brain inflammation, again, it's not a far-fetched concept. And can this lead to future issues? Potentially, even infection. So viral infections, herpes in particular being such a common one, herpes infection over and over time. There has been, some research showing how Alzheimer's patients and dementia have some of these viral particles in the brain, potentially coming up from the body to the brain because of the leakiness, whether it's from age, whether it's from diet, lifestyle, and loss of sleep being the number one, I think, way that we create leakiness in our blood-brain barrier. So over time, if you have these infections, bacteria from acne, viruses, fungi, so we know that they can penetrate the brain, and then down the line, they could potentially lead to dementia and Alzheimer's risk. So that's kind of where I want to focus on for this particular lecture, because I know that we talk about psychological stress and things get worse when you're stressed, but what else can get worse? How does it get worse? Is it what molecular pathways are being investigated that show that this inflammation that you started on your skin caused the inflammation 30 years later in the brain. And we're very slowly kind of getting there, but I think getting these concepts out is how we will approach mental health through the peripheral nervous system. And this is just one very recent paper that we just published, and this is on all of the different approaches for atopic dermatitis or eczema. We have, itch and stress and all of these conditions. And there's a lot of mind-body therapy. So we do also know that they work, and that there's so many different ways. I know there was a couple questions about massage touch therapy, and I'll touch on this one in a little bit. So when it comes to the nerve fibers, we have done an extensive amount of work on the brain-skin connection when it comes to the nerves, right? Because we know the sensory, we understand all of these different receptors that are so specific for heat, pain, itch, and more recently, social touch, which I think is one of the most important elements of our skin-brain connection. And also, I think how we might be able to solve some really fascinating issues that we might not be able to tap into, like anorexia nervosa, like maybe interoceptive disorders. And I think social touch will play a massive role in that. I'll talk on that a little bit. And so when it comes to effective touch, this is from years and years ago. So now we know that we are hardwired to the emotional brain. We're not talking about the somatosensory cortex, how you feel when you touch something, but we're now talking about the insular cortex, how you feel when you've been touched. And I think the most fascinating thing about this is that your prefrontal cortex can override that insular cortex. That's a key thing to understand for people, because they will know that, you might stimulate your C-tactile fibers in the skin, and somebody might stimulate them for you, but your prefrontal cortex could still override that and say, nope, I refuse to feel good about this. And so that's where trauma comes in, that's where somatic, disorders might come in, that might be even autism spectrum disorders. So this is where a lot of those issues lie, whether it's interoception or whether it's touch. And I think there's so much to learn about the brain, in particular when it comes to these skin fibers. And just as an example, we have, all of these different kinds of touches, and you could probably see, just have a look at these little boxes and what you experience when you see them. You might see, and again, you're not looking at the eyes, which is a big part of how we do this, but in the face, you can only see the arms, and you can see maybe a shove, you can see a hug, you can see a nice caress, you can see pulling. So this is just interesting in terms of showing how much you might feel as you even just view these. So you don't have to feel touched yourself to activate a lot of these centers in your own brain. And of course, releasing neuromediators like oxytocin and serotonin, et cetera. And when it comes to how aroused we are, it could be something like seeing somebody get kicked and shoved or hugged, because in both cases, our arousal is up, and the valence, meaning whether it's a positive touch or a negative touch, it has this sort of U-shaped curve. So in the lower valence, those are the negative things like pushing, they still arouse us. They still cause us to feel that. And on the high number valence, so these are the positive things, they also cause the same sort of arousal. So I might have mixed that up. In either case, whether you see someone get kicked and pushed or hugged, we are still aroused, because as social creatures, we are stimulated by how people touch each other. And that's just so crucial to our own humanity and how our brain functions in general. So I think, can we talk about mind-body issues more than just brain issues? When we talk about touch affecting so many parts of the brain, oxytocin, I mentioned, and endorphins, the modulation of the stress axes. So looking at issues of interoception or autism or things like that, anorexia, I think we'll be able to tap into those. And we already are, in a sense. There's already things like compression, for example. I think compression therapy is where all of this kind of lies. And we can maybe train the skin CP fiber. We can't change the density of those fibers, but we can maybe change how they respond in order to feed back up into the brain and make meaningful changes so that we have better functioning lives at the end of the day. And of course, when it comes to emotional health, we feel that in different parts of our bodies. So, when we talk about mental health, a lot of the things that pop up are, depression, anxiety. These are the things that are sort of plaguing and have probably plagued humans forever. And especially now, because we're so connected and we see each other online, on social media. And so the fact that we are even more intricately connected with each other, with people that we've never met, we might be able to sort of harness that connectivity and that power that we have within ourselves to show, emotional health, and maybe even treat, emotional health. This is kind of where I'm going at. Can we treat emotional health through a variety of things? I think in particular with gentle touch therapy is where we will see that. These are the things that we already know. So far in this whole lecture, all of the things I've presented are things that we already know. And so we know that gentle touch therapy can have a massive impact on the developing brain and also on how we can respond to different things. And so in terms of the future, what are we going to be able to see with what we know now? And I think starting with touch, again, we will be able to potentially treat some future issues, potential issues, because we already know that with premature infants, you can do the skin-to-skin contact to prevent major issues in whether it's cardiac health or pulmonary health, even brain health. So again, just understanding that and knowing how to tap into that. And there's already research around this, trying to tap into the gentle touch to stimulate those fibers, in particular, 3 centimeters per second. So specific, 98.6 degrees Fahrenheit. Like, it's just the most fascinating fiber, I think, on nerve in the body, maybe besides the vagus. They're just so amazing. These tactile fibers, they're found in the skin, but there are also, these elements in the follicles of the hair itself. So this is just showing the outer root sheath cells. They also release ATP and histamine and serotonin. So in response to mechanical touch, now we know that these touch receptors are predominantly found in hairy skin. So it's the stroking of the skin at that specific velocity, at the specific temperature, but also because the hair is there. So because the hair has a compartment of nerves and it's connected to the nervous system, it's connected to the endocrine system, but it is a mechanical thing, then what's interesting is that we might be able to tap again into this touch center through the hair follicles in a more specific way, and looking at the peripheral stress axis, because this particular substance, this unit also releases serotonin. So I think it's going to be a new target in the future. We talk about skin in general, but I think the future of all of this is going to be going from macro to micro. Now we can microscopically sort of touch and tap into all of these things now that we know so much more about all of these systems than we did even a decade ago. And another really fascinating area are, opsins. All of the opsins that are found in the skin, like there's so much room for for neuroplasticity and changing the brain, the central nervous system potentially through the options. So if you imagine a therapy where you're not just using maybe compression therapy and touch therapy, but with also light therapy, then you can stimulate a larger packet within the skin, the living skin. So you can tap into, the opsin receptors, activate opsin receptors, and also you're talking about like the hair follicle, the root sheath, changing that, and where is that going to lead to? Potentially, it is going to affect the skin's peripheral nervous system and the way that it responds to its own cortisol release, or maybe it can also affect the general central nervous system in some way. And just a brief overview of the light. This is just for your information to know, like which options respond to which wavelengths of light. Obviously, there's infrared and ultraviolet as well. So I think that's important to know because you've probably seen an infrared sauna in every other corner now. So, these are wavelengths that do penetrate the skin. And we talk a lot about blue light as well. So really targeting and harnessing this information, I think, will be one of the future applications of how we can create better light therapy, because now we will know which opsin receptor you're looking at in which part of the skin. Are you looking at the melanocyte? Or are you looking at the keratinocyte, or which specific cell? So I think, again, going from macro to micro is going to be a big part of this. And when it comes to opsins, again, in the lower left, you can see the penetration of the light itself. Just another illustration of it. Blue light doesn't penetrate as deeply as red wavelengths. And I think when it comes to optogenetics, right now, optogenetics is, everywhere in neuroscience and brain health and animal studies. But can we maybe move that into the peripheral nervous system? And I think that's really interesting and important, because when it comes to pain in particular, pain is, it's something that is in the brain actually, but you feel it in your skin. So it is in the peripheral nervous system and the central nervous system. So looking at these targets might be one of the ways that we can solve neuropathic pain, diabetes, and all of those things that can lead to these kinds of pain in the skin. Maybe we can target that through simple things like light. And another very interesting aspect of this is, can we check for neurodegenerative diseases in the skin? And yes, I think we can, because we already are doing that. So with Parkinson's disease, you can take a punch biopsy and look at the red staining in the bottom is alpha-synuclein. So alpha-synuclein clumps up in the brain, and by the time that Parkinson's is actually diagnosed, I think you have an irreversible loss of 70 to 80% of the dopaminergic neurons in the substantia nigra. So most of the dopamine is gone from this area, and that is affecting the motor aspect of Parkinson's. And of course, the neurodegeneration has already started, where we've wiped out 80% by the time somebody is clinically diagnosed with Parkinson's. Can we use the skin to preemptively target, to look at signs of Parkinson's in the skin? And yes, I think we can. We will just get better at it. So down there, you can just kind of see in the green and the red is where neurons are marked and where alpha-synuclein is marked. And so in the yellow is where more things, where they merge. And then in the two right boxes is they just these computerized sort of zooming in. So as we zoom in and zoom in and zoom in, again, we're going from macro to really micro with the technology that we have. So I think this is really, really exciting, because we don't have to wait until someone is already lost 80% of their dopaminergic neurons in the substantia nigra. We can actually potentially look at this from the periphery even earlier. And same thing with looking at specific cells, again, macro to micro. We're looking at the melanocyte. Can we look at that as the center of a lot of things? It has opsin receptors, it has the hormones. It is a neuroendocrine unit on its own. So I think, again, we talk about the ectoderm, skin cells, keratinocytes, brain cells, but don't forget about the melanocytes. And another aspect of this was a really interesting recent study looking at skin parameters changed between healthy people and people that have Alzheimer's disease. And what's really interesting is you can see the pH of a patient, the pH of the skin of a patient with Alzheimer's disease is much higher than the pH of a normal healthy skin person. Why? We need to find that out. Also, the hydration. Why is that so much higher in somebody with Alzheimer's disease than in a regular healthy patient? My guess is that the level of hydration affects the pH. So why is the skin more watery, let's say, with Alzheimer's? That's so interesting. And I think when we understand that, we will be able to tap into that circuit to potentially prevent or just have a good biomarker for Alzheimer's disease in the skin. And same thing with Parkinson's disease. Again, we're talking about, here's what I mentioned about earlier about rosacea, migraine. So again, neuroinflammation being a center of all of this, and with Parkinson's disease as well, Alzheimer's disease. And we're talking about neurodegenerative diseases affected by the skin heavily being the largest organ, but also all of the changes in inflammation in the brain body. And finally, when it comes to technology, I think we all know, we're all aware how artificial intelligence is changing daily life. And here are two very awful pictures that AI generated. And you can see that the woman has like a tentacle instead of a hand. And the other picture has like a brain on the cheek. So awful. Artificial intelligence is not perfect. And I think we just need to know this and always understand that even as artificial intelligence becomes potentially hyper intelligent, meaning much more intelligent at processing everything than we are, which is not, again, outside the scope of reality. We just need to know how important it is for us to stay on course and train correctly, because you can have an AI system that helps a dermatologist, but if it's not trained right, if it reads literature from the 50s and it doesn't take into account more melanin in skin, so darker skin types, for example, then it won't know how to treat a darker skin type person. So there's a lot of fallacy when it comes to AI. And even, and sorry, Katerina, I got to point it out too, even like the image for this conference, you know, I was like, oh yeah, half of it has the brain, but there's like a whole brain in half of it. So AI is just not there yet. So we don't need to worry about that, but please, for the love of all that is good, stay close to, just do the human work that we're working on. I think that's super important to keep that as we move forward. And when it comes to skincare, you know, I think the possibilities are endless. At this point, I'm not seeing massive innovation. But we can, you know, we can hopefully future get more innovative skincare as we do this. And, you know, when it comes to our nervous system, it's not just in our heads, it's in our hands, it's everywhere in our body. Thank you.
Lovely, thank you. Great talk. And, you know, some biology targets there, local and systemic for technologies and other interventions. So would encourage everybody to read both of your papers. People like that, right? So we do not have Alison Layton. She's traveling. She's in Amsterdam at EADV, and we play her video, which Jill will upload. Thank you, Claudia. We will ask questions in the panel again. Everybody, if you could please put your questions into the chat channel. Okay. We can't hear that, Jill. So maybe we could go again, and just a few words from me. So Professor Alison Layton is the leading consultant dermatologist at Hull York Medical School. I've known her for about a decade, and she has practiced psychodermatology in acne and rosacea before this term was really coined. Very kind to her patients and really a best acne specialist in the UK, I would argue. She will speak today about acne lesions, I believe. Would you like to go again? Thanks. We still can't hear that. Jill.
Hi all, I'm not quite sure. We practiced this earlier and it was working fine. Just let me try again once.
So if this is not possible, we do have a plan B. So we will share with you Alison's presentation and go straight to the panel. However, I would like it to work if it can.
Of skin disease.
Yes.
So I'm going to say a little bit about the UK perspective on psychodermatology in practice. So what is a psychodermatological disorder? Well, as I'm sure you're all aware, it's also known as psychocutaneous medicine. And essentially, it describes the complex interplay between the skin and the mind. And the condition that results has both physical and a psychosocial component. And it's very clear nowadays in dermatology that we are well aware that if we're going to effectively manage the skin disorder, we need to take into account the psychological and the psychiatric factors that ensue, maybe as a result of, or maybe driving that skin disorder. And researchers are now using the term neuroimmunocutaneous system or neuroimmunocutaneous endocrine system because we understand now that there is a complex interplay between all these different aspects. And I'm sure you've heard quite a lot about this already. So I expect you've heard quite a lot already about this complex interplay between the skin, the brain and the guts, and there's some excellent research ongoing to try and disentangle some of these complex interplays between pro-inflammatory and inflammatory cytokines, which can exacerbate skin disease but also mental health issues. And there's also a lot of interest in how an inflammatory skin disease may produce or be associated with systemic effects. So this was actually a discussion at a psoriasis and mental health workshop where they actually explored the links between psychosocial factors, the psoriasis as the inflammatory skin disease, the neuroinflammation in the brain, but also cardiovascular risk, which has been shown to be increased in our patients with psoriasis. So this complex interplay is a fascinating area, and many researchers are actually looking to understand the systemic processes that are going on, which will potentially help us improve the well-being of our patients generally, but also improve their mental health and their skin disease. So how do we classify psychodermatological disorders? Well, essentially, we can classify them into three categories. First of all, there are a number of inflammatory skin diseases where emotional stress can exacerbate the symptoms. So we frequently see that in psoriasis, atopic dermatitis, but also things like acne and rosacea. So common inflammatory skin diseases often get worse in the context of stress. We also see a second category of patients with a primary psychological disorder. And that psychological condition itself can result in skin problems. So, for example, patients with delusions of parasitosis, patients who have significant itching, pruritus, which produces nodular prurigo, and these patients have a primary psychological disorder that requires treatment. And then the third category represents secondary psychological disorders which have resulted from the skin disease itself. And this is particularly common in patients which have visible skin conditions that are disfiguring, and these may lead to all sorts of symptoms, including social phobias, depression, anxiety, and can also lead to misuse of substances and alcohol. So this was an interesting all-party parliamentary report which was published in 2020, and essentially asked participants how their skin conditions affect their emotional and psychological well-being. And in fact, 98% of those that responded said that their skin condition had a profound effect on them emotionally and psychologically. And 5% of them actually suggested that they expressed suicidal thoughts. So this was actually quite an important report to try and emphasize the impact of skin disease from a psychosocial perspective. And in the literature, there are a number of helpful reviews. This was a systematic review and meta-analysis which demonstrated within the context of multiple papers that there was an association with especially chronic skin disease on anxiety, depression and suicide. So a couple of examples were with atopic dermatitis, and a second one was in acne. And there are similar publications demonstrating that patients have disease-associated stresses, so certain things will actually trigger their disease and make things worse. And it can be a catch-22. So, for example, in atopic dermatitis, you might get itching and physical discomfort, which alters appearance, which then actually contributes to the stress and makes flare-ups worse. And interestingly, there are reports of adverse childhood experiences being associated with atopic dermatitis, and there's very clear association of stresses with acne flare-ups. I'm going to say a little bit more about acne, because acne is a very common condition, generally seen in adolescence at a time when young people are actually going through significant psychological transition anyway. It's the 8th most prevalent disease worldwide, so extremely common, and about 9% of the population will have acne at any one time, which translates to about 650 million around the world. And obviously one of the main problems with acne is it is incredibly unsightly, and the most common site is the face, and it's not surprising if you have acne which is moderate to severe like this is going to have a very profound effect on you. But patients may have quite subtle acne and still feel very self-conscious. One of the other problems with acne can cause pigment changes, particularly in skin of colour, and very, very frequently causes scarring, all of which can contribute to psychological and social social problems. One of the issues, I think, for patients with acne is we're living in a very cosmetically aware environment, and people are using a lot of social media. So actually looking good is really important, and acne clearly can have an impact on one's appearance. And this was a large impact review that we did and published 2 or 3 years ago now, where we looked at all the studies that have ever identified negative impacts on acne, and we tried to tease out what were the worst aspects for our patients. And of 408 studies, 22 of them used qualitative data, so interviewed patients very carefully to see what was most important to them. And the top one was definitely negative self-perception, both in terms of their self-image, the way they saw themselves, the way they thought they were perceived by others, and this translated to feeling very self-conscious in situations. So appearance-related concerns really figure very highly in acne patients. And this can actually translate into all sorts of different problems for them. So negative effect on relationships, they don't like going out or interacting with their peers. Negative effects on their daily activities, so they may not want to do sport and they try and conceal their acne, particularly if it's on the trunk. Fear of negative evaluations, and that translates to them being anxious about going to social situations, withdrawing from social situations, and being very sensitive in interpersonal relationships. There's also clearly evidence that patients with acne get teased, stared at, and they feel that they're stigmatized. And many of them will actually adopt coping strategies in terms of compensatory behaviors to try and actually cope with their visual acne. And they have a lot of concerns about their future and whether their acne might impact on opportunities. This is an interesting study which actually compares the impact of acne on quality of life with other chronic diseases. So if I said to you, how do you think a patient with asthma, diabetes, back pain, or epilepsy might fare in terms of social functioning, having fulfillment in life, having mental health issues, and impacting on their well-being, energy, and vitality, you might presume that those might all be impacted negatively to some degree. But what I found quite interesting with this study is that acne is very similar, if not worse, in terms of these different domains, and therefore I think really highlights the impact that acne can have in terms of the physical and psychological sequelae that it can cause. I mentioned post-inflammatory pigmentation, which is common in skin of colour, and this can last many years, and it can lead to very significant social impairment for our patients, low self-esteem, depression, isolation, and suicide, all of which have been reported as they have in acne. And in terms of scars, this can have a significant burden on our patients. The worse the scarring, the worse the burden, not surprisingly. And if patients have scars on more than the face, i.e. on the trunk as well, then they are likely to experience much more in the way of impaired quality of life. And one of the things I think that's very interesting about acne scarring is that it is going to cause more psychopathology in patients than the acne alone. So that really emphasizes the need for us to try and actually intervene early and to actually try and prevent acne evolving for our patients. And that actually reflects on use of dermocosmetics. There's been a lot of work recently looking at the impact of dermocosmetics early on in the course of acne to impact on the microbiome, which is impaired in acne, and also to try and actually improve the skin barrier integrity. So cosmetics can play a significant part in acne The other area which is very interesting is the impact of skin disease on stigmatization, both from the perspective of the patients, so them feeling they're stigmatized, but also when you actually look at some of the results from studies that have been conducted, it's very clear that we perhaps subconsciously do stigmatize patients with skin disease. And this was a nice paper published last year, which actually quantified the stigmatization that can occur in our patients. And if you look at stigmatization from the acne patient's perspective, they're very likely to report stigma compared with healthy patients with no disease, and about a third of them report bullying. And one of the things I think that's very interesting about this is that perceived stigma is a strong predictor of quality of life impairment, and more so than actually the severity of the acne or the socioeconomic factors. And the final thing that acne patients will complain about is that they often feel dismissed by clinicians that say, oh, it's just a bit of acne, it's a rite of passage. They feel unfairly treated at school, and they feel that they're likely not to do as well at work in terms of opportunities and also dismissal. And exactly the same sort of thing happens with acne scarring. Over a third of the patient feels that it affects people's attitudes to them in a very negative way. They feel that they've been subjected to negative comments, and again, it's impacted negatively on their work. And if you actually evaluate whether those acne patients are right, and we show people normal faces, i.e. with no acne, versus faces with acne lesions or scars and marks, then their perception of those patients changes very significantly in terms of them being seen to be shy, less socially active, more likely to be bullied, less successful in their jobs. So really interesting that we do stigmatize patients subconsciously according to the way their skin. One of the challenges with psychodermatology is although it's well recognized as a subspeciality of dermatology, there is a real paucity of infrastructure to enable all dermatologists to actually deliver good care for patients. And this was a position paper published by the Psychodermatology Task Force from Europe, just outlining, and it's an interesting paper if anyone wants to read it, but it certainly clarifies that we need to do much more to support our patients from a psychodermatological point of view. There are now various psychodermatology associations around the world, and the British Association of Dermatologists is very supportive of this, but it does require multidisciplinary approaches to ensure that patients get the best advice, and resources are short around the world to do this. So are there any tools that we can use in the clinic? Well, this is actually just a paper which looked at all the different quality of life measures, health-related quality of life measures, patient-reported outcomes that have been used in acne. And you can see that there's very many around. The Dermatology Life Quality Index is the most frequently used, I think, across all dermatology conditions, and is useful in terms of actually picking up on some of the impacts that the skin disease can have on quality of life. So I've included this slide because it just really emphasizes that in acne, if we use good dermocosmetics early on in the disease course, and alongside treatments that potentially might cause irritation on the skin, we get good results, and you can see that the quality of life is improved. So I think the cosmetic industry can play a large part in trying to impact on quality of life, and we know that dermocosmetics impact on both the microbiome in acne as well as skin barrier integrity, and that also applies to other chronic inflammatory skin diseases. So really can play a big part in terms of improving quality of life. And I just wanted to end by sharing this slide with you. So this was a patient on the left-hand side with lovely normal skin, and they described this as the acne trip. So as they developed acne, they became what they described as a non-entity on that right-hand side. And it's very impactful to see that. It's also interesting that even back in 1948, this quote by Sulzberger, the understanding that skin disease could produce significant psychological and social problems with both the affected person and the family was recognized all that time ago. So apologies again for not being with you. I think psychodermatology is a fascinating area. I think that there's room for cosmetic approaches to it, to improve people's skin diseases, to think about how we can actually impact on the microbiome, the skin barrier integrity, and achieve better efficacy and results for our patients. Thank you. So many thanks for inviting me. I'm so sorry not to be
You
there.
can, you can switch it off now, Jill. Great, so we will go to the panel now to answer your questions, but if you can please join me in thanking our speakers for their time and expertise, you can, by a little reaction perhaps. Thank you.
So thank you to everybody. There's quite a few questions coming in. If you have any more questions, please pop them in the chat. It's been fascinating. And further to I made a comment earlier on that when I was explaining this to somebody yesterday, and they said, oh, I thought that was just all marketing rubbish. And actually, no, it's not. It's clearly a very serious endeavor. And the idea that we can influence mental health through the skin is definitely here to stay. I'm just going to read out some of the questions. If anybody's got any questions and wants to put their hand up, then they can do so if they want to ask it. But let me just start off with some of the questions that came in earlier. So questions for Timo, if Timo's still here. These are from Claire Higgins. If you give the effective touch protocol at a non-hairy site, do you see the same effect as the effective touch at a site away from histamine administration? So that's, I think, comparing non-hairy with the non-histamine. So is Timo still in the audience?
Yeah, I'm still there.
Hi.
Don't worry, I haven't run away. So of course we haven't done that. But what I would expect based on the presence of CT afferents only in the hairy skin, you wouldn't see a benefit because it will trigger a completely different cascade. So what it will trigger is something that's very similar to the control conditions that we have used. So the two control conditions were kind of fast touch, which is kind of triggers mechanoreceptors, and the tapping, which also triggers mechanoreceptors. So yeah, no, you wouldn't see a benefit. Or less of a benefit, because it could work still, because it distracts you. Anything that distracts you from the edge will still give you a benefit.
Yeah. So a follow-up for you, Timo, again from Claire Higgins. She says, do you think the effective touch is leading to a change in the brain, which reduces the ability to sense itch? Or is it a local effect having an impact on histamine levels in the skin?
Again, I've got a hypothesis, which may or may not be true. I believe it is an effect in the brain. So we kind of looked at this kind of as a way of basically overriding the itch signal through the brain, because in the end is kind of I talked a bit about the different brain mechanisms, and there's a really key mechanism. There's the thalamus as a kind of a gatekeeper of what's actually being perceived. So if you give the brain different signals, there's only so much that the brain can deal with, and reality is basically constructed based on the different inputs. And so I expect it's going to the brain, and then kind of it's overriding whatever kind of itch signature is coming to the brain.
So is that
but obviously, there's still loads of work we can do and should do on this.
Yeah, so is it similar to gating pain signals,
Yeah.
through rubbing a bruise or whatever?
Yes.
So Katerina says she's interested in a well-designed self-massage could also evoke altered states of consciousness, thus replacing the negative repetitive behavior. So I think that's maybe Claire could pick that one up.
Yeah, thanks for that. I think that the answer to that may well be yes. Other things that I didn't have time to tell you about relate to how a whole range of animals use repetitive motion and a variety of repetitive motion to create this sort of altered state of consciousness for themselves. So my favorite are ruminating reindeer. Reindeer actually ruminate, which means they chew endlessly, which puts their brain into a kind of semi-sleep state. And so I think that there are all sorts of ways we could use movement and interactions with our bodies to do similar things. And by the way, I think that in terms of helping people with BFRBs, I think that Timu's observations in relation to itch are almost exactly transferable, because I think that the urge to pick and pull and bite is very much like an urge to itch. Scratch.
Karishma has asked about factors contributing to acne, specifically in relation to dietary habits, skin manipulation, or emotional behavior, and whether they play a significant role. And we don't have Alison here, but I wonder, is Keira still here?
No, she isn't. Oh, yeah, she is. Keira, hi.
I'm here. Yeah. So I'm sorry, the question was, what are the contributing factors to acne?
Yeah, particularly in relation to dietary habits, skin manipulation, and emotional behavior, and how much they play a significant role.
Yeah, I mean, back when I was in residency, they told us that diet didn't play a role, but we know that that's not true. And I think with any condition, it's never just the one thing. It's all interrelated. And so I think of it as a bucket analogy. How full is your bucket? If you're eating processed foods, high glycemic index foods, that can create an inflammatory cascade, right? That nice network. Our nervous system, if you're stressed, if you're not sleeping, if you're not moving well, if you're surrounded by people and an environment that is a stressor to your system, then your immune system is going to be activated. That's going to directly affect your skin and our hormones. So I would say it all can impact. But what we know, especially in our stress response cycle, that gut brain skin axis is crucial. So when especially if the mental and emotional component, one thing that's going to go offline is your digestion. You do not need to digest food when you are in a stressful state. Gut motility will slow down. I mean, I'm oversimplifying it, but gut motility will slow down, though that will potentially contribute to an imbalance between the good bacteria and the bad bacteria. And we know the bad bacteria can release things like lipopolysaccharides, which can poke holes in the gut, making a leaky gut, sending inflammatory signals, leaky gut, leaky skin. And then you've got that bidirectional communication. So I think it's never just one thing, but for individuals who are really struggling with acne, starting, I guess, with the lowest hanging fruit. Some people doing the internal work, the emotional work, that is the hardest work we will do. So oftentimes people focus on dietary changes or lifestyle changes first, because as you have success and you start to see improvement, it creates more capacity and space to do some of that inner work. So that is a very long-winded explanation to say it all matters, it all contributes.
Thank you. And we've got a question from Anetta. Is there any data comparing groups that feel actively ashamed of their skin condition versus those who don't feel overly stressed about it? So comparing the ashamed versus the okay, presumably with the same skin condition, just to dissect that difference.
I'd
So
say,
yeah, I'm not
I'll
sure.
just chime in.
Yeah, go on
I'll
then.
chime in here. There have been, you know, the studies on the level of skin shame and the amount, the significance of disease burden and disease severity compared to those who didn't experience as great shame. So there is some data around that.
Okay, well, I guess Anesta can email and we can put her in touch with you or perhaps Alison for some of that information. So Ella asks, I'm curious to know if hair removal, waxing, laser, shaving has an effect on innervation of the hairy skin. Will it reduce the benefits of slow touch?
Yeah, I think it's an interesting question. So if you, because I think there's the scientific answer, which is like, no, hair removal doesn't change the innervation of the skin. And there's actually a study looking at depilation, and that also doesn't change basically the positive, so affective touch perception. So that's the scientific answer to that. Of course, having hair on your skin does change sensory perception. So in that sense, yes, you will perceive. So it's kind of, if I shave my face will feel very different than if it's natural.
Yeah, well,
so
I mean, there's
so
a
that's
big
like,
habit.
that's the awkward one, but it doesn't abolish kind of like the fact that CT afferents will still fire. So it's not like if you pluck your hair, CT afferents will go away.
But the slow touch, how much is the hairs present contributing to the slow touch and the benefits to well-being?
I don't think anyone looked at it like systematically. There's only like the studies that actually looked at it. It's like if kind of there is depilation that doesn't have an effect.
Yeah, I think Francis might. I don't know if he's still on the call, but Francis.
Absolutely. I mean that's not right, Timo. I'm sorry.
Yeah. Okay.
We're about to publish a paper looking at every hair fiber that we touch is responsive to a CT stimulus. So they're definitely innervated by CTs. But if you use saran wrap on the skin and try our inverted U function, it goes flat. So there appears to be some relationship between the hairs and the perception of affective touch. Although that may not be the whole answer, by the way. But so yeah.
There is a practice of dermablading, which has become very popular recently on the face. And I don't know whether losing those fine hairs from all around the surface of the face will actually have any impact unless you're trying to evoke that response.
Well, people who pull out all of their hair could probably inform that discussion. Yeah. I'd be surprised if pulling out a hair actually changes the innervation either. I mean, I think the innervation probably stays exactly as it is.
Yeah, well, the innervation around the follicle is in the upper permanent part of the follicle in the main.
Exactly.
So, but I guess Claire and her team might be able to look at the difference between hair follicles that have been plucked and not.
Yeah.
And then
Claire, and apparently
Francis
has something that you'll publish very soon, so we're looking forward to that too.
Yeah, right. This is 4 years of work, team. As you know, microneurography is not an easy task, but every single hair we individually pull that is innervated by a C-tactile afferent, they all fire. We don't know the functional connectivity, by the way. It's just the association is that every hair, when you touch it lightly, the CT fires. But I've always made the point that these CTs are in the epidermis as well. So there's a long way to go. And by the way, I need to thank Unilever for providing me with the money to actually research the C-tactile afferent and give it its.
You've been doing it a while.
Yeah, well, 25 years, just about. People are listening finally. It was reassuring to hear so much affective touch discussion today, because it is the nerve. It's the nerve that underpins the benefit of grooming behaviour. And I've always said, you don't necessarily groom to look good, you're grooming to feel good, but you don't know it.
Very good. So there's Claire Mackay asks, I wonder whether the distinction between the disorders that are primarily dermatological versus primary psychological is real. Maybe it's just we don't understand the mechanisms.
Yeah, so that's just a reflection really on listening to talks about psychodermatology and seeing that line put in the sand. And as you heard from me talking about trichotillomania, I think that it is a dermatological condition. I mean, I don't mean that there aren't psychological elements, but again, also listening to that last talk, the overlap in terms of the shame and the disintegration of the self. And I mean, it was virtually, I could have given that same talk about trichotillomania. So I'm just not so sure that distinction between, I think that sometimes we can put things into a psychological bin just because we don't understand the mechanism, but actually I'm not so sure that that distinction's real.
Yeah. And I was fascinated, Claudia, about your suggestions on the origins of things like the HPA axis being in the skin, and actually the hair follicle has a complete HPA axis as well. So Des Tobin once wrote a really nice article called "Your Skin, Your Brain on the Outside." It's probably out of date now. Maybe it could be done with being revisited by some of you guys to update it, because of the relationship, I think, between some of these mediators like POMPs genes, for instance. They're very ancient, and therefore they were probably much more to do with the protection of the, originating primordial species than what we think about them and their function today. So I think it's fascinating, and I've worked a lot with Philips doing light therapy, and I think certainly visible light does interact with the skin cells and hair follicles, and at more than just red wavelengths, which is kind of what everybody seems to be using. So I think there is a real possibility to treat perhaps psychodermatological disorders using light therapy on the skin, which may then have benefits through well-being as well. Oh, you're muted, Claudia.
Sorry. Yeah, I was just saying I agree. I think with red light in particular, you're tapping into the nitric oxide system and the skin peripheral, ATP generation and all of that. So I think I didn't talk about it in this lecture, but I think one of the other elements of this future talk is also on mitochondria and energy and re-energizing at the cellular level. The different compartments of cells, in particular mitochondria, and I think light has a lot to do with that, and also at the neuromuscular junction, in particular with Parkinson's disease. Everybody gets Botox, and like I agree with Francis, I do think that when you either rip out a hair or when you attack the muscle nerve interaction, it could have some lasting effects that we maybe not see all at once. But I think it could lead potentially to some issues. Again, there's papers now that say, oh no, Botox doesn't cause any changes in the neuromuscular junction. But I think, how could it not? Also, ripping your hair out, like how could it not affect everything that is connected under there? So anyway, I do think there's a lot that we can investigate under the surface.
So has anybody got any last questions that they didn't put in the chat or that they'd like to ask, or comments from the speakers?
Ella's got her hand up, Jill.
Oh, I can't see everybody. So please, oh yeah, Ella, please go ahead. Thank you.
Sorry, I think I've done that by mistake. But thank you for the hair removal. I was thinking more of damage from ripping hair out, so thank you.
And I think Francis made the comment about where's the neuro in psychodermatology. So maybe we need to be psychoneurodermatology. Is that right, Francis?
If you don't talk to the mechanisms, you'll be making up stories. It's my humble opinion. but yeah, I think we need to bring those two sort of disciplines together, because the mechanisms drive everything. Yeah, and this whole meeting is ultimately about C fibers. And Claudia's point as well. I think these C fibers evolved before the fast stuff, and each one, the pain one, the itch one, of which I have an Ig Nobel Prize, by the way, and the pleasure one, they all protect. Yeah, every one of those 3 C fibers protects. And I think that's a fundamental part of psychoneurodermatology, is the role that this grooming behavior evolved a protective role as much as anything. The immune system, the brain, everything. So let's rock on with C fibers. And when they go wrong, it's devastating, as we know, chronic pain and chronic itch. But the C-tactile often doesn't seem to have a deficit in terms of its absence, other than a lot of psychiatric conditions, possibly, but that's yet another story.
So perhaps the last question from us who've staged this from CCUK. This is a sort of an ongoing activity of Katerina's over many years, and she's collaborated with all of you guys. We'd like to do something or to support something more proactive happening. So what do you guys think? Should we have a one-day or a conference? Should we have something, your next year's one at Oxford? Could it be focused on skin care? Is it sufficient to have a topic all of its own? Do we need to have, maybe more thinking and less talking? I don't know. What do you think?
Well, in relation to Oxford, this skin was represented brilliantly by Francis, but I think there's plenty more, including a lot that I've heard today, that wasn't actually there, and so it would be great to have a bit of a BFRB psychodermatology combo day together.
Psychoneurodermatology.
Psychoneurodermatology.
Okay. In fact, just a closing, there's my group that I work with in Sweden and beyond. I've got a paper in Nature coming out soon on RNA-seq of human dorsal root ganglia. This is every single neuron that innervates the skin has now got an RNA-seq. So we'll know every ligand, every molecule. And the hot news here is that we may have a marker for the CLTMR. So that paper's coming out in Nature soon, I think. And that will change everything in somatosense.
Yeah, Jill Dunn is commenting, saying that the York event last year in April worked well. I think we felt we had low attendance, haven't we? So that's why we've done it online this year. And obviously we can bring in the west coast of the US, which we wouldn't have been able to do, in person.
I mean, we can bring in video links to give talks or ask people to record a presentation. But I think this topic seems to be rather split between the dermatology community and the research community. And I think what we're trying to do, we've got a huge number of industry people who've registered for this talk. So I think what we would try and do as CCUK is to bring the dermatologists, the academics and the industry people together to have, a fuller workshop and more discussion. Claire, hi.
Can I just add, since Francis mentioned Hoken's paper, which points to the hair as being quite important, I think, and also the CT fibers innervate the hair. Claire, in her talk, mentioned a little bit about it, but obviously my personal interest would be to have a hair-brain connection discussion.
Well, maybe what we can do is
it drives everything.
We can write out to everybody and do a little follow-up sort of review of the meeting, and then we'll come up with some suggestions. And it sounds to me like what we did in 3 hours, we could probably do again over a couple of days.
I think they're
a very interesting topic.
We've got L'Oreal, we've got Chanel, we've obviously Unilever, we've got a number of these companies that I think would help us put together a really well funded meeting to get all the different perspectives. But
fabulous.
Certainly worth doing.
Okay.
Well, thank you very much, everybody.
Thank you.
We've reached our allotted time. So thank you to all the speakers. You kept on time brilliantly.
Thanks.
And it's been fascinating. So I've really enjoyed it, and I hope you have too. I will take the recording down, and I'll probably need to do a bit of editing. So I'll hopefully make it available to people who would like it in about a week's time. So thank you.
Thank you. Bye.
Thank you.
Yeah, bye-bye.
Thank you.
All right.
Bye.
Thank you very much.
Okay.
Jill, I'm going as well, but let's recap, okay, Jane? Bye.
Yeah, well done. It was really, really interesting, fantastic insights, and to get people from across in the USA and all around the world listening, I think it's amazing.
You just need to.
Thanks both.
Thank you. I'll see you later then. Bye.
Bye.
Yeah, well done. Bye.